Now, may I request Dr. Rohit Om Prakash sir to speak on how do you manage when we have a PC tear with an overlying nucleus?
Thank, thank you, Dr. Deepak, for the opportunity. So I'll be taking up PC tear with an overlying nucleus. Can be Phaco. This was what was asked by Dr. Deepak for me to speak about. Well, the primary objective of when we have a PCR is to have a safe and thorough cleaning of lens fragments. And the secondary objective is do an IOL implantation. Now let's see some scenarios where there is a pre-existing PCR, like patient with anti-VEGF multiple injections. So this patient had repeated anti-VEGF injections. Visual acuity following last injection increased from 6 by 32, 6 by 36 to 6 by 18 and then dropped to finger counting in 2 months' time. So we did we did a pre-operative OCT and realized that there was a PCR. Now the question was whether we should go in for an anterior approach or we should go in for a posterior approach. Well, with the new machines and new fluidics, we went in for the anterior approach. So the strategy was to use low IOP settings as has been propagated by Bob Osher and Abhay Vasavda. Consider the patient as a posterior polar cataract with pre-existing defects. Use flax if possible. Sizing of rexes, as Dr. Saurabh has said, should never be more than 4.8. Hydro procedures should be avoided. Rotation should be avoided, and chopping techniques have to be customized. So now let's see this patient. You know, in this patient, a 4.8 millimeter capsulotomy was done. Calibrated side port incision was given. Capsulorhexis was completed. The fluidics you will find is with around 20 IOP pressure. With this 20 IOP pressure, the bottle height is around 28. The aspiration rate is flow. I'm going around sculpting with the slow motion concept because I do not want to overinflate the chamber, which I've been able to do with less IOP. There's less infusion of pressure. The nucleus is being separated completely. Once this complete separation of the nuclear fragment is done, I know that the posterior, the capsule is going to be, exposed to it. So this low IOP is helping me because there is less amount of fluid which is being infused into the anterior chamber. There is less posterior bulging of the posterior capsule, as has been shown by Vasavdas, that with an intact capsule, you can have an anterior hyaloid phase rupture if you use high fluidics. So this low fluidics is helping me create a situation wherein I am not letting any vitreous phase to be broken whatsoever. I am doing slow motion phacoemulsification at the level of iris and slightly anterior to it because I knew that it is a soft cataract and the process is being continued without any problem whatsoever. This is only possible if you are able to create a situation wherein you have stable chamber settings with these fluidics. Usually with the active sentry and everything, with all these active fluidics, there is least amount of fluctuation in anterior chamber. You can see the side port incision which I am using is also very important because stable chamber settings are very important. With the femto delineation, I have kept away the posterior capsule also. I am using a coaxial one with a slight modification. I have retracted it. With this retraction, I have tried to create a situation wherein the irrigation and aspiration have different level of flow, and this is being done. And this femto delineated, this epinucleus or the nucleus, the posterior nucleus is now being aspirated. And since it is being done, it's difficult at times, so it is going around with a very slow pace. And I'm trying to just, stuff it in so that I'm able to do, total aspiration of the posterior part of the epinucleus. Once that is done, I implant an intraocular lens, which in this case would be a 3-piece. I did not venture into going in for for a single piece and do reverse optic capture, because I thought that I was not comfortable at that point of time. But this is an option which I would definitely go in for, keeping in mind that the capsular axis size was small, and now I am doing the optic capture. So so you can see how with a posterior capsule rupture you can go ahead with low fluidics and complete emulsification, and this is triamcinolone coming into force and showing the absence of vitreous whatsoever in the anterior chamber. So this is another patient wherein there's a posterior polar cataract with pre-existing posterior capsular defect. In this patient, anterior segment OCT is very important. Low IOP settings, low motion phacoemulsification, stable chamber settings, sizing of rexes, no hydro procedure and chopping techniques as I've already shown. So let's see this video. In this video, you will find that there's a 41-year-old lady who had bilateral posterior polar cataract. High expectations were there. This is a moth-eaten type of posterior polar cataract. You can see the posterior posterior capsule is not intact. Visco is being no overfilling of the anterior chamber. Calibrated side port incision. Rexis of my choice is the oval rexis, as shown by Kiranjeet Singh from Amritsar. This gives the advantage of both a small and a large rexis. So now I'm starting with sculpting. The IOP is 26, which I will gradually reduce. I'm continuing with sculpting, and the moment I sculpt, I find that I have reached a situation where it is neither soft nor it is hard. And when I'm trying to separate it, I'm not able to separate it. I try to do cross chopping. I'm not able to do that. So in this situation, I'm just trying to debulk it and use the the escape route, as Bob Osher always says. So I'm trying to create a situation where there is now I'm trying to do that is the escape route. Now what is the next thing which I am doing? I am trying to do centripetal dissociation of the nuclear fragment. So this is being done in a low guarded manner. I can see the posterior capsule has given way, and it is a very tricky situation. IOP has been further reduced by me to 24. I'm going around with us in a slow motion manner. Stable chamber settings are being applied. And now what is the next thing which I'm going to do? I'm going to do visco separation. This visco separation is going to be done so that I'm able to separate it from all sides. So I'll try to separate it in the sub-incisional area also. Once that is done, I have a free floating, epinuclear nuclear mass, and then with, slight repositioning of the nuclear fragments, of the last nuclear fragment, I'm trying to reposition it, and you can see how I'm able to do it. Once that is done, with this low IOP, wherein there is hardly any difference it's a physiological IOP totally, low fluidics whatsoever, a nucleus floating, not being pushed behind, with the visco and the low fluidics, I'm able to complete emulsification by totally dislodging it from the periphery. Once that is done, you will find that emulsification is complete in a very slow motion manner. So you can see now it is being completed. Now once that is completed, I'm using stable chamber settings. Next, what I'm doing is I'm doing the Gills-Welch dry aspiration. In this, the steps are irrigation, aspiration, fixing, teasing and stripping. You use a 25 gauge cannula, and then I'm visco expressing it out. So you could have used a bimanual also. Triamcinolone being used, and you will find there is hardly any vitreous disturbance in this patient. And once that is done, I can easily implant an intraocular lens. I am using a 3-piece intraocular lens in this situation, and I'm going to do the optic capture using the smaller rim of the an oval rexis, and you will find that it is complete, spindle shaped as Dr. Saurav has shown. Triamcinolone again, and you can find now that the case has been adequately completed. This is the post-op day 1. and the patient was very happy. Take home points: anterior segment OCT, low IOP settings, use slow motion phaco emulsification, stable chamber settings, sizing of rexes, oval rexes or a small rexes, no hydro procedure, no rotation, chopping techniques to be maneuvered. Thank you very much for your